I'd like to set the stage for this morning's program by beginning with a video which shows two people who are dealing with life-limiting illnesses. One is Shirley Waring, the other is Maury Schwartz. Are any of you familiar with the book Tuesdays with Maury? Yeah. Yes. Some of you are. This is the same Maury Schwartz who wrote that particular book. And what I'm hoping is that this video clip will put a concrete face on the issues that we will be discussing. It is called Living Fully Until Death, and I assure you that it's not morose, but that it really does have a more positive orientation. So let me begin with that. Is there anything that was said on the film that really struck you? Or did this video and what was portrayed on it raise any questions for you about end-of-life issues that you would like to see answered this morning in the course of our program? Again, any comments that really struck you? Yes?
For Shirley, who ultimately decided to no longer pursue chemo treatment, how do you know what's natural death? Is it no treatment at all and just letting nature take its course and dying, or how much medical treatment do I need to pursue and when do I start that?
Okay, very good question. We will be addressing that, yes. Don't be shy.
Well, you know, the act of dying can be an act of sharing.
The act of dying can also be an act of sharing. Would you like to say more about that?
Too many people hold it in, and they don't share with their loved ones.
Okay, they don't share with their loved ones. And that's the point Maury was really making.
Mm-hmm.
Yes.
That we are a community. We are there to support and be with each other. And if you don't let them in, that's a gift you're not getting.
Thank you. Other things you notice from the video. For example, many people say that they're afraid of dependency as they get older. And Maury's comment was, if you have to be dependent, enjoy it. Okay. Enjoy what other people are going to do for you. And I think that's a very important attitude.
I have one other question.
Yeah.
Can you, I don't know if it's part of this talk, can you bury ashes at the place where you want?
Okay, I don't have that information. Yeah. And again, this was not in the state of Iowa. Okay, now both Maury and Shirley had to make decisions about using or foregoing life-sustaining treatment. Maury talked about a ventilator, and he decided he didn't want that, at least at that time. Shirley made a decision about chemotherapy. She had undertaken it at one time, then decided to stop it. So the first topic I would like to address is what the church has to tell us by way of guidance about using, foregoing life-sustaining treatments. And there is a printout of the PowerPoint to pass out. Now, just some examples of what is meant by life-sustaining treatments. Ventilator support, chemotherapy, radiation therapy, sometimes blood pressure medication to keep up somebody's blood pressure can be a life-sustaining treatment, antibiotics against infection, kidney dialysis, blood transfusion, surgery, resuscitation. All of these are examples of what is meant by life-sustaining treatments. I'm going to be referring to a document called the Ethical and Religious Directives for Catholic Healthcare Services. This is a document from the United States Conference of Catholic Bishops, which provides a nice summary of church teaching on various issues in healthcare ethics. Now, the U.S. bishops didn't just invent what is said there. It is all based on Vatican-level teaching. I'd like to start the discussion with a theological framework. We do recognize that life is a gift from God, and that we are stewards of our lives, stewards of this gift, not absolute owners of it. And as stewards of our lives, of this gift from God, we do have a duty to preserve our life, but that duty to preserve life is not regarded as absolute. Because we also recognize that life on this earth is not our final reality, not our final goal, but that we are destined for eternal life with God. And since we recognize we are destined for eternal life with God, and that death is the transition to eternal life, the Church recognizes that it can be permissible to forego life-sustaining treatments. The Catholic tradition makes a big distinction between foregoing a life-sustaining treatment, that is withholding or withdrawing a life-sustaining treatment, and euthanasia and suicide. It can be permissible, according to Church teaching, to forego a life-sustaining treatment, whereas euthanasia and suicide are never considered morally permissible. Right now I'm going to focus on the first, foregoing life-sustaining treatments. At the very end of our program this morning, I'll talk a bit about euthanasia and assisted suicide. Today, there is a big emphasis on what's called autonomy, patient autonomy. That this is the right of a person to direct the course of his or her own life, to make treatment decisions. Shirley was very much promoting autonomy when she said, well, it's not my husband's decision, it's mine. Now, this is what the Ethical and Religious Directives for Healthcare Services has to say. The free and informed judgment made by a competent adult patient concerning the use or withdrawal of life-sustaining procedures should always be respected and normally complied with unless it is contrary to Catholic moral teaching. So we respect the decision of the person, but the person needs to make that decision within the framework and with the guidance of principles that the Church has presented to us. Sometimes patient autonomy is presented as if the patient were just making a decision and pulling it out of the air. We can ask what principles should guide the person in making his or her choice, and that's what I want to talk about. How many of you have heard of the distinction between ordinary and extraordinary treatments? Okay, a number of you have. Okay. This is a distinction that was accompanied by the principle that ordinary treatments should always be provided, but it is permissible to forego treatments which are extraordinary in character. And this is a distinction in principle that is centuries old. It goes back to the Renaissance. Now, over the years, different meanings came to be attached to the terms ordinary and extraordinary. And there were seen to be some counterexamples to this principle that ordinary treatments always had to be provided. You could always forego treatments which are extraordinary in character. So beginning with the Vatican Declaration on Euthanasia in 1980, there was an attempt to clarify what is meant by ordinary and extraordinary treatments. And that was done in terms of a concept of proportionate and disproportionate means, which was in turn understood in terms of the benefits and burdens of a treatment. And this is what the Ethical and Religious Directives for Catholic Healthcare Services now says in explaining the ordinary and extraordinary treatment distinction. A person has a moral obligation to use ordinary or proportionate means of preserving his or her life. Proportionate means are those that, in the judgment of the patient, offer a reasonable hope of benefit and do not entail an excessive burden or impose excessive expense on the family or the community. A person may forego extraordinary or disproportionate means of preserving life. Disproportionate means are those that in the patient's judgment do not offer a reasonable hope of benefit or entail an excessive burden or impose excessive expense on the family or the community. So to sum it up, an ordinary treatment is one that is proportionate to the results you get, which means that it offers a reasonable hope of benefit without any excessive burden. An extraordinary treatment is disproportionate to the results you get, which means that it does not offer any reasonable hope of benefit, or it is excessively burdensome for the person. Now, this has come to be known as the benefits and burdens principle. So what are some benefits a treatment may have? Well, the treatment obviously will be beneficial if it brings about a cure, or even if it improves a person's health status in some way, it's beneficial. Treatments are beneficial if they relieve pain, if they increase the patient's mobility, if they will restore the patient to consciousness, if they will improve the patient's ability to communicate with others. And these are just some examples of benefits, not necessarily an exhaustive list. But again, benefits of treatment are conceived very, very broadly. Similarly, burdens of treatment are thought of rather broadly too. Obviously, if a treatment causes a person pain, that's a burden of the treatment, or substantial discomfort. We can think about the side effects of chemotherapy, for example. Also, psychological burdens of treatments are recognized as well. For example, it's not unusual for people who undergo kidney dialysis to become very depressed, and that depression that accompanies the dialysis is a burdensome aspect of that particular treatment. Or again, a burdensome aspect of a treatment may be difficulty in getting access to the treatment. I've seen a Catholic healthcare ethicist even take into account something like driving distance to get a treatment as a possibly burdensome aspect of it. Suppose, for example, you live in the rural area of Iowa and you need kidney dialysis, but to get to a dialysis center, you're going to have to drive 2 hours each way 3 times a week, including during dead winter. Just the brute driving distance to get to that treatment can be a burdensome aspect of it for you. Or again, in some cases where people have feeding tubes, they need to be physically restrained so they don't pull out the feeding tube. Those physical restraints are a burdensome aspect of the treatment for that particular person. Or again, if you look at the ethical and religious directives, cost factors are mentioned. Now, it may surprise some people to know that you can take into account the cost of a treatment in evaluating it, but that is explicitly mentioned in church teaching. According to this benefits and burdens principle, it is morally permissible to forego, that is, withhold or withdraw life-sustaining treatment under either of 2 conditions. First of all, if the treatment offers no real hope of benefit to the patient, if it's useless or futile. For example, there are 2 types of pneumonia. One is bacterial, one is viral. Antibiotics are effective against bacterial pneumonia, but not against viral pneumonia. So if you have viral pneumonia and use antibiotics, it's not going to do any good. It would be futile to administer the antibiotics. No obligation to do it. Or again, people may have, let's say, a heart condition which makes them unable to tolerate tube feeding. In that particular case, the tube feeding will work for them physically. It would not offer them any benefit, no obligation to use it. So if a treatment offers no real hope of benefit to the patient, there's no moral obligation to use it. Similarly, if a treatment is going to be excessively burdensome for a patient, it's considered morally permissible to forego it. And what does it mean to be excessively burdensome? Often that's understood in terms of the burdens of the treatment outweighing the benefits. And Shirley Waring's decision about chemotherapy on the video is a good illustration of this particular point. Now, she initially started chemotherapy. It wasn't working, so they tried a more toxic form. But that more toxic form of chemotherapy caused organ damage for her. Liver and kidney damage, a bleeding ulcer, esophagitis. And if she continued with the chemotherapy even further, the next round would cause heart and liver damage. So that the treatment was not helping her in any way, but in fact was further harming her body. So she reached a point where the chemotherapy could be considered excessively burdensome, perfectly permissible morally to forego it, as she did. Now, who judges the benefits and the burdens? It's from the perspective of the patient, or if the patient is incapable of making a decision, the proxy should say how the patient would evaluate that situation. Now, in practice today, the benefits and burdens principle has replaced the ordinary extraordinary treatment distinction in this sense, that if you have a conversation with healthcare professionals about your situation, they will be talking in terms of benefits and burdens of a treatment rather than using the distinction of ordinary and extraordinary treatments. Now again, the benefits and burdens principle is not something new. It's our current understanding of the ordinary extraordinary treatment distinction. Now, when we were explicitly using the terminology ordinary and extraordinary, it was as if we were labeling treatments as such. Aspirin, ordinary, you always give. Kidney dialysis, extraordinary, you can forgo. When we talk in terms of benefits and burdens, there is no treatment that you can automatically forgo. There is no treatment that you automatically have to use. Rather, decisions are made on a case-by-case basis. What will this treatment do for this particular patient who is in this particular situation? So going on a case-by-case basis, there are, for example, cases where you would want kidney dialysis, other cases where you might legitimately decide to forgo it. Now, at one time, some people wanted to make a distinction between withholding a treatment, never starting it, and withdrawing a treatment, stopping it. And some thought you could withhold but never withdraw. Now, both ethically and legally, it is considered just as permissible to withdraw a treatment, to stop it, as never to start it in the first place. Okay? And this is the reasoning. In some cases, you may not know in advance whether treatment is going to benefit someone or not. And if you have this mentality, well, once I start the treatment, I can never stop it, you may be afraid to try the treatment because you don't want to lock in someone you love into something that's doing nothing more than prolonging their dying process. But that may mean, too, that you never try a treatment, that the patient never has the opportunity, the chance to benefit from it. So what is recommended today is a time-limited trial. If you're not sure if the treatment is going to be beneficial or not, try it for a defined period of time, then evaluate how it is going. If it is helping the person, wonderful, but if it's not, then you should feel free to stop. Emotionally, psychologically, it may be more difficult to stop a treatment than never to start it. But ethically and legally, it is just as permissible to withdraw a treatment to stop it as never to start it in the first place. Finally, I would like to say something about proxy decision-making. Again, I'm quoting from the ethical and religious directives. Decisions made by the designated surrogate should be faithful to Catholic moral principles and to the person's intentions and values, or if the person's intentions are unknown, to the person's best interest. This standard articulates what are the two accepted standards in healthcare ethics in general for proxy decision-making. The gold standard is considered the principle of substituted judgment. The proxy knows the patient well enough that the proxy can predict what decision the patient would make based on the patient's written or oral directives. Here's where advanced directives come in that we're going to discuss later. Or the proxy just knows well the patient's beliefs, values, preferences, lifelong behavior patterns. For example, my paternal grandmother was in a nursing home about 10 years before she died. The aides in the nursing home even had difficulty taking her temperature because she'd take the thermometer and throw it across the room. Now, when somebody behaves like that, you know that they are not going to go from being in the ICU in the hospital and connected to all kinds of tubes and machines. So from her behavior patterns, one could make a prediction about what she would and would not want in terms of treatment. Now, connecting this with the principle of benefits and burdens that we were talking about, the proxy decision maker should ask the question, how would the patient judge the benefits and burdens of the treatment? The proxy does not ask, what do I think of the benefits and burdens of the treatment, but rather, what would the person I represent say about the benefits and burdens of the treatment? Now, there may be a few cases in which you really don't know what the person would want whom you are representing. Say maybe you're dealing with someone who was mentally challenged since birth and really could never understand these treatment decision making, the decisions that have to be made. A standard used in those kinds of cases is called the best interest standard. The proxy attempts to make a decision that is in the patient's best interest. In law, we have a standard of what the reasonable person would choose. So you might ask the question, what would a reasonable person in these circumstances want done in terms of using or foregoing treatments? And again, connecting this with the benefits and burdens principle, you can ask the question, how would a reasonable person judge the benefits and burdens in this particular case? Now, again, I want to emphasize that what I'm talking about in terms of using foregoing life-sustaining treatments is very, very different than euthanasia and assisted suicide. When you decide to forego a life-sustaining treatment, there is a natural disease process going on that is the cause of death. When you're talking about euthanasia and assisted suicide, you're talking about a human action that is the immediate and direct cause of death, not a disease process as such. So it's not a natural death. Now again, the main thing I want you to get out of what I've said so far is an understanding of the traditional ordinary, extraordinary treatment distinction in terms of a consideration of the benefits and burdens of the treatment. And at your tables right now, I'd like to invite you to have some discussion about this. Have you personally experienced any situations in which a decision had to be made about using foregoing a life-sustaining treatment, either for yourself or a family member, okay? What decision was made? And thinking about it, can you think about that decision in terms of the benefits and burdens of treatment? Now, in the event that you can't think of any case offhand like that, we do have a case study that we can give you that raises precisely that question. So maybe we could just pass that out as sort of a backup. But the idea would be if you could spend some time talking about a real-life situation you've encountered where decisions had to be made about using foregoing life-sustaining treatments. So we'll give you a few minutes to do that.